Ladies and gentlemen, dear students, welcome to this month's edition of case presentations in nephrology, an initiative of the Indian Society of Nephrology. So before we start, just let me clarify that there are frequent requests from many of the students to access the previous cases. So you can access them in ISN's YouTube channel, in which all the recorded sessions are present. So before we go on, for the information of all those who are joining for the first time, this unique academic initiative was started by ISN for our dear students to promote academic knowledge and revive the classical case presentations, the clinical case presentations, stressing on history, points to be taken in negative history, general examination, systemic examination, and have a diagnosis and a discussion based on that, without depending on full-fledged investigations and latest tests. And this also helps us in preparing for the examinations for all the students who are appearing for NBE or DM, because your exams will be based on that. So I would request all of you to please join the event and register in advance, so that we can send you all questions, articles, and the recorded videos. And so today's session, we again have a case of kidney transplant. So kidney transplant is not just one topic. So there are many aspects of kidney transplant, and you invariably will get a long case of kidney transplant in your exam. So we'll be discussing different facets each time. So today we have taken a specific facet of kidney transplant, and we'll have a short case presentation followed by discussion, and then all those who want to ask questions, they can send their questions. So for our today's event, we are very honored to have Professor Vijay Kher sir, who is a teacher of our teachers and one of the revered and esteemed teachers of not only India but worldwide. Sir has got numerous qualifications to his credit, and sir is presently working in Delhi as the chairman of nephrology and transplant of the Epitome Kidney and Euro Center. And sir has got the rare distinction of establishing several major teaching departments of nephrology all over the country. That includes Sher Kashmir Institute of IMS Srinagar, the SGPGI Lucknow, Apollo Hospitals Delhi, Fortis Hospitals NCR, Medanta Medicity Gurgaon, and I am very sure that that many of the teachers or the faculty who are attending here, including me, we all have been students of sir and have attended his clinics in the past. And sir is a key member of various societies of national and all over the world. He has held the highest post of the ISN as the past president of ISN, and sir has got numerous awards, orations, and distinctions to his credit. And he is an expert, is a member of the expert panel of the International Society of Nephrology, KDGO Transplant Group, ICMR, and various others. And he has got numerous publications, chapters, and has edited books. So apart from that, as we know, sir, he is one of the best teachers. And every time we meet him after an event or a conference or in a session, so we learn something from him. And I don't think that there is anyone better in the country today to teach us transplant than sir. So Dr. Mradula Shukla, who is a senior resident nephro from IGIMS Patna, will be presenting today's case. So I request all of you to please be muted, and any doubts, questions you have put in the chat box, we'll take them in the end. I will also request all the students to participate in the discussion and try to answer the questions. So it will act as a revision for all of you. And we look forward to your feedback, suggestions, comments. We are trying to evolve and improve. So look forward to your ideas. So you can join our WhatsApp group so that we keep sending you updates about the next cases, case summaries, and all. And with this, I would like to request Dr. Mradula to share a screen and start a presentation.
Thank you, Vineet, for that huge introduction. which wasn't probably that much needed, but thank you very much. And I would be very glad for to have come here and to discuss the presentation which Dr. Mradula is going to present. Dr. Mradula, you can go ahead.
Good evening, respected faculty members and my colleagues. Today I am presenting case of Mrs. S. Pradhan. She is 36-year-old female, Hindu by religion, and she is resident of Darjeeling and is educated up to graduation. She is housewife by occupation, and informant is patient herself and her husband. She is a case of second live related kidney transplant, and she came for her regular OPD follow-up visit. Patient was apparently well till November 2015 when she developed generalized weakness, which was present since last 5 months, and swelling over body, which was present since last 3 months, and decrease in her urine output since last 15 days, and shortness of breath for last 1 week, and single episode of epistaxis. With the above complaint, she visited a local hospital where she, on further evaluation, was told to have failed kidney function, and was diagnosed with hypertension and anemia, and she was told that her kidneys have shrunken based on the ultrasonographic finding. uh, uh, However, she did not have any history of recurrent pregnancy loss, hemorrhagia, photosensitivity, any history of joint pain, any history suggestive of Raynaud's phenomenon, or any history of redness of eyes, diminished vision, or any history of nocturia, polyuria, intake of any alternative medication therapy or chronic analgesic intake, or any history of calculi. When she in Darjeeling, she was advised for renal replacement therapy initiation, but she came to IGIMS Patna in December 2015, and she was started on hemodialysis. And she received 3 hemodialysis through the femoral catheter in the right side, and then next 3 sessions by left femoral catheter, and right internal jugular venous catheter hemodialysis line was inserted in January 2016, and which was removed 1 month later due to catheter-related bloodstream infection. Later, she was right left-sided IGVC was inserted, which was also removed after 1 month due to catheter-related bloodstream infection. Uh, in February 2016, our AB fistula was created. But a first AB fistula was failed, and second AB fistula was created in brachiocephalic region on left side, and it was successful. During that course, patient was stable and was maintained on 2 antihypertensive drug, and was given subcutaneous injection for anemia, which she used to take twice weekly, and she was vaccinated for hepatitis B, pneumococcal vaccine, and influenza. She was counseled for kidney transplant, and her 50-year-old mother with blood group O, patient's blood group O uh, uh, came out as a prospective kidney donor, and after detailed pre-transplant evaluation, she was accepted as and taking clearances from the concerned department, she was accepted as donor, and her kidney transplant was planned in March 2016. In March 2016, however,
Can we stop Mradula here, and can you summarize and suggest that what do you think was the cause of her kidney failure? What, in your opinion, if you are presenting this patient and you're listening when the patient comes to you in an outpatient, so there's a certain sort of thought process which goes in your minds. So what do you think are the likely possibilities of her underlying native kidney disease?
that based on her history, as she presented with the edematous illness, I would like to, and hypertension, I would like to keep the possibility of chronic CGN as the first, and in CGN I would like to keep the possibility of IgA nephropathy in our set of patients who are
So
present.
why do you think that this has got, when she came to you and presented with end-stage kidney disease, isn't it? She presented
Yes,
with end-stage kidney disease. And the
yes,
total history that she gives you is of 3 months history of swelling over the body. This is,
yes,
isn't
sir.
it? So if
Yes,
it is 3 months history of swelling and then she reaches end-stage kidney disease, so you think this swelling was because of glomerulonephritis at that point of time, or it was because of end-stage kidney disease or advanced kidney disease and salt and water overload?
sir. At that time, she was maybe she had some swelling, but she did not notice the minor swelling and the
When?
presentation.
When was that? When was that? See, her
s-
total presentation, the history that you give when she was diagnosed with end-stage kidney disease is total of about 3 to 4 months of history.
yes, sir.
She doesn't give you any previous history of any swelling or anything. See, which condition progresses in 4 months or 5 months or 6 months? What kind of glomerulonephritis progressed to end-stage kidney disease requiring dialysis and transplantation in 6 months' time?
Sir, rapidly progressive glomerulonephritis can
So
progress,
is
and
so
in
is
that,
her history something like rapidly progressive glomerulonephritis?
sir, she had a history of generalized weakness followed by which could be because of the uh, generalized weakness and malaise type of picture could be because of the vasculitis and
So the question should be, whenever one goes into differential diagnosis of many of these conditions, when the patient is right in front of you and you're listening to the history, your point should be a broad kind of a, that this could be glomerulonephritis, but I don't know. Glomerulonephritis, I would have wanted that she had maybe some history a few years back, then she had swelling, she was treated for some disease, then you can make proteinuria was one of the features which was there of long standing, and that progresses over years. Rapidly progressive is a subacute kind of an illness. This is a patient who presented with end-stage kidney disease. She was diagnosed with bilateral small shrunken kidneys. So what are the conditions which can cause bilateral small shrunken kidneys in a 36-year-old lady?
sir, in a 36-year-old female, if we are keeping the possibility of chronic glomerulonephritis, then the lupus nephritis is there, which can, if it is having a rapid progression or crescentic RPGN type
But
of presentation.
this history doesn't speak of a crescentic GL. No? This history doesn't look like a crescentic GL. Does it give you a picture of crescentic GL? I don't know. Small shrunken kidneys would tell me of something long-standing, that
Yes.
this disease must have been there for some period of time. So what are the common causes of bilateral small shrunken irregular kidneys?
And sir, if there is any history of chronic analgesic intake, then irregular small kidneys, maybe because of the analgesic nephropathy, then due to reflux nephropathy
Yeah,
also.
reflux. So I would think of an interstitial nephritis, chronic, maybe a reflux nephritis. And many times you haven't told us whether there was any history of early childhood fevers or recurrent urinary tract infection. That is what I would have wanted to be in the negative history. You did look at lupus, you looked at glomerulonephritis, because I think your mind was stuck on the diagnosis of chronic glomerulonephritis. Bilateral small shrunken kidneys could be glomerulonephritis, but they are more often due to chronic interstitial disease, which could be because of drugs, which could be because of usually an interstitial infection, pyelonephritis in the early childhood, reflux nephropathy, and all others. So they would be there in my differential diagnosis at that point of time. So I would have looked at that as a possibility. And whenever you're looking at differential diagnosis, keep your possibilities broader. So one could be glomerulonephritis, one could be interstitial nephritis. She hasn't given you a history of prolonged hypertension and all those things, but one needs to ask whether she had hypertension and all. During pregnancy, she's had how many pregnancies?
So single child.
Single child, but during the pregnancy, you said that there wasn't any evidence of hypertension or any manifestation of renal disease because, at least, so what would it? When was the pregnancy? Last pregnancy?
Sir, currently his child is 16-year-old, and the
The
transplant
child is
was
16 years old. Okay, so what does it tell you? What does it tell you? If she had had a successful pregnancy and
that
somebody with kidney disease, so what does it tell you? At least can you date kidney disease? At least say that at that point of time, her kidney function must have been
was
reasonably good, so
good,
that she has had a successful pregnancy. So that
successful pregnancy.
there may not have been as much of hypertension at that point of time, because that's a bad prognostic sign for successful pregnancy, and kidney function must have been reasonably okay. At least 16 years back, she didn't have it. I cannot otherwise date her kidney disease after that, because I don't have any clues about this history, and you haven't told us about, because I thought that you were sort of, even in your negative history, highlighting mostly glomerular disease and lupus or something. And whereas when you are looking at the history, the examiner will notice you what are the things that you've not talked about. And I think this was somewhat missing, and I feel that your thought process was interstitial. I can't totally rule out. I think bilateral small shrunken kidney in a young lady, I would think more of chronic interstitial nephritis. And even though end stage kidney disease will present the same way in glomerular disease as well as in the interstitial disease, hypertension, many times even diabetes, they are not very different as far as end stage disease is concerned. They will present with advanced kidney failure symptoms, and many of the symptoms that she presented with could be all as a result of advanced kidney failure, isn't it?
Yes,
Okay,
sir.
go ahead.
Sir, she was planned for kidney transplant in March 2016. However, she developed fever with itchy vesicular rash, which was diagnosed as chickenpox, and she received antiviral treatment for that. And her kidney transplant was postponed. And after the resolution of her infection, she was continued with the maintenance hemodialysis twice per week at her native place, with regular with OPD follow-up. And at that time, during maintenance hemodialysis, her urine output was approximately 200 ml per day. She was for the further for transplant. She was admitted in kidney transplant unit and IGIMS on 14th of June 2016, and was started on oral medication, which were tacrolimus and mycophenolic mofetil on 14th, and she received a session of hemodialysis on 15th, and in the evening she received IV drug, which was probably solumetrol, which was infused over a duration of 1 hour. And on 16th she was started on some costly IV infusion, probably ATG, and was shifted with the same drug to the OT at around 9:30 a.m. During the intra.
So how would you be sure that this was thymoglobulin and not any other induction agent? So how would you find out actually, even if the patient doesn't tell you? So is there
Sir,
a method in that a physician like you could know from the history itself, or ask a direct question as to what kind of drug it would have been? Would it be thymoglobulin or something else?
so first of all, sir, I'll ask the cost of the drug. What was the approximately
And
cost? And then what was
she
the
may
route
not
of,
know the cost. She may not know the cost. So how would you
then,
find
sir,
out?
route of administration, and via the central line
Mm-hmm.
or via the peripheral line, and over
Mm-hmm.
how many, at what time it was started, and was she shifted with the same to the operation theater, as probably ATG is also ATG is also given in the intraoperative period, and what was
How
the
much is
duration
the
of
dose
infusion.
of thymoglobulin which is given usually?
Sir, at our institute, we give Graflon, which is given at a dose of 2 to 5 milligram per kg, and otherwise thymoglobulin, which is from Sanofi. It is at a dose of 1 to 1.25 milligram per kg. And
Okay.
sir,
So how is it given, and for the infusion is given over what period of time?
Sir, preferably it is given via the central venous catheter because of the risk of thrombophlebitis. But if the patient, if we cannot give it via the central venous catheter, we can give it by peripheral line also, or even through AV fistula. And we give it over a duration of 4 hours, and we gave it with the pre-medications as it is associated with
Yeah.
the
So the type of infusion, and how is, if you were to use basiliximab, how is it given? How much is the dose which is given? Have you used basiliximab?
Sir, I have seen one transplant in which a basiliximab was used. It is given at a dose of 20 mg at day 0 and day 4.
Okay.
Uh, yes.
So over how much of period? You remember it, or you haven't? Have you been to the transplant theater as such ever, or you
Sir,
not been to the transplant theater?
sir, I have seen ATG more as compared to basiliximab.
So basiliximab, yeah, usually in about an hour. So the duration of, sometimes, although patients may not be able to tell you once they are in the operation theater, and therefore, but usually the time frame of infusion, most of the time, and the thymoglobulin is usually given, if you give divided doses, usually they are given next day or third day, whereas basiliximab is given on 0 and 4 days itself, fixed in that kind of a fashion. So these infusions and the history with which they are given, that will tell you whether this is thymoglobulin or it is ATG or basiliximab. These are the kind of induction agents which are used in these. Okay. Is induction agent necessary in every transplant?
Sir, as per KDO, we prefer to give we prefer to give induction therapy until unless the patient is uh, uh, twins, or we can avoid
Yeah,
induction
unless they are identical twins, or
identical
HLA,
twins. We can
or an
haplo
HLA mashed, full
haplo
house matched.
identical.
Yeah,
Yes.
two haplo identical uh, donor and recipients pairs, then you may not give induction as per diagnosis. When was the guidelines given? The
So
KDIGO guidelines are,
2009.
yeah, 2009. So they're very older guidelines. So current, the KDIGO hasn't revised yet the transplantation guidelines. So they need to revise it. So there is better evidence to suggest that probably you may use induction agents as ATG as a better induction agent in the current era of tacrolimus and mycophenolate mofetil. But anyway, we will discuss this maybe later as well. So you can go ahead.
During the intraoperative period, she received 1 unit of blood transfusion, and no history of any intraoperative complications was there. And patient was received back in kidney transplant unit at around 4:30 p.m. on oxygen and had good urine output. She was discharged on post-op day 12 on a standard triple immunosuppressive regimen that was tacrolimus, mycophenolate mofetil, and prednisolone, and one antihypertensive drug. And at discharge, as she recalls, her creatinine was 1 milligram per deciliter, and urine output was approximately 4 liter per day. She was under regular follow-up on OPD basis with tacrolimus blood level in appropriate range. Serum creatinine was in the range of zero point 0.8 to 1 on further follow-up. In August 2016, she was found to have raised blood sugar, for which she was started on oral medication. And Patient had a poor compliance to MMF as she was living in remote area and was not able to get the medications on time. And also in 2000 August 2016, she developed low TLC count, for which her MMF was put on hold for approximately 2 weeks. And during further follow-up towards the end of August 2016, her creatinine level started rising from 1 milligram per deciliter to 1.8 milligram per deciliter over the duration of next 3 weeks. This rise in creatinine was not associated with any fever, increased urinary frequency, burning micturition, uh, cough, loose stool, vomiting, rash, tremors, or any worsening of hypertension. And her tacrolimus level was also within the appropriate range. And she was
What kind of ranges do you follow at IGMS? Say within the first 3 months, what is the kind of TAC levels that you would want? And between 3 to 6 months, what kind of TAC levels? And after 6 months, what kind of TAC levels? So,
Sir, at the initial period, we keep a higher level of tacrolimus, that is 8 to 12, 8 to 10. Then at the later, we keep it at around, sir, 6 to 8, and then 4 to 6, 4 to 6 after the, sir, 1 year.
6 months, after about
Yes,
1 year to 1 year,
6 months.
4 to 6 nanograms. Yeah, that would be the levels. So usually 8 to 12 in the first 3 months. And you could go down as you go the months wise, but then 6 to 8, and then about 4 to 6, usually in about 6 months and beyond, then 4 to 6 nanograms, and usually try to keep the TAC levels around 5 and above these days, because TAC remains the backbone of immunosuppressive therapy. So one should try to optimize the dosages of the TAC to a reasonable TAC levels. Okay.
Yes.
Okay.
And sir, some other costly investigations were also done, which were found to be the normal limits.
Which is what kind of costly investigations would have been done?
Sir, probably donor-specific antibodies and BK virus, PCR, and
So a BK virus PCR would be a good test to do to find out graft dysfunction. So that could be in the early transplant periods up to about 1 year. BK virus nephropathy
yes.
would be definitely a differential diagnosis, and rejection would be definitely a rejection. But what kind of rejection would you think she would develop in this? Especially a patient where compliance with some of the drugs, as you said, especially mycophenolate mofetil, was low. You said that she wouldn't get the medicines in time and may not have been able to take. So what is the kind of rejection that you get usually with?
Sir, rejection, probably, sir, if it was because of the preformed DSA, then it is during the first 3 months we can think
So,
of.
but what kind of tests were done to find out preformed DSAs in this patient? So what was the kind of cross match that was done? CDC cross match?
CDC, flow cytometry, and single antigen beat.
All
Sir,
three were done? All three were done at the time of transplant?
for sir, she was found to have CDC was negative, and flow cytometry was also negative, sir. I
Okay.
did not find the report about single antigen beat
So
for the
maybe
patient.
they didn't do it. In fact,
Yes.
I also don't do it. If the CDC cross match and the flow cytometric cross match is negative, then I usually don't do it. I find if your flow cytometric cross match is good and you can swear by it, then I would feel that probably one could not necessarily, unless there is history of sensitization. So how do you assess history of sensitization?
Sir, if it is there, if the patient has history of multiple previous history of previous transplantation, previous
Previous trans
blood received multiple blood transfusions,
blood transfusions and
or by
previous transplant
pregnancy.
and pregnancy in women pregnancy. So she has had one delivery. You
Yes, sir.
said that she received some blood transfusion somewhere at the time of dialysis,
Yes, sir.
isn't it? Yeah.
Yes.
So some blood transfusion. So she is sensitized from that point of view. She's had a pregnancy. This was her first transplant, and she's received some blood transfusions, maybe not large ones, but at least few transplantations, few blood transfusions. So to some extent, there is sensitization history there, and I would also surely would look at in these patients who are sensitized, then these patients I would look for single antigen beats as well. And if it wasn't there, maybe it wasn't done. And this time, so they did this test and they may have found that there wasn't any preformed antibodies, or there are no donor specific antibodies. Okay.
Yes. So,
So she was admitted again and the kidney biopsy was done.
yes, sir. She
Okay.
was admitted again and kidney biopsy done on 15th of September 2016. And during her hospital stay, she received injection Solumetrol 500 milligram for 5 days. And she received subcutaneous insulin during that period due to uncontrolled blood sugar levels. And after 1 week, serum creatinine level declined to 1.5 milligrams per deciliter, and patient she was told that she was having low graft dysfunction due to rejection, and she was discharged on standard triple immunosuppression and was under regular follow-up after that. During the
So
further,
what do you think was you don't know the kidney biopsy report, or you know the kidney biopsy report?
no, sir, I don't.
You don't know the kidney biopsy report. Okay. So, but can you make a surmise that what kind of rejection it would have been?
So probably it was a cellular acute cellular
So
rejection.
T cell
T-cell mediated rejection was there,
mediated rejection, and
and
T cell
sir,
mediated rejection. Why does it occur in a patient who is already received thymoglobulin and is on reasonably good immunosuppression of tacrolimus mycophenolate? So, what is the incidence of T cell mediated rejection currently? On an average, in good centers, what would be the T cell mediated rejection like on a thymoglobulin induction?
exact percentage, sir, I don't.
Anyone in the about 5 to 7, 8% or so, less than 10%, at least. Previously, the rejections prior to the thymo induction used to be something like 12 to 15% or so, and prior to any induction, on a cyclosporin era, the rejection rates used to be something like 30% or so, and I have seen rejections to the extent of about 40 to 60% when there was these newer forms of immunosuppressive drugs like tacrolimus and mycophenolate were not available. So you may not have had cyclosporin also. So azathioprine and prednisolone therapy, sometimes the acute rejection rates were very, very high. So over the years, with the newer induction therapies and with the new immunosuppressive therapies like tacrolimus and mycophenolate mofetil, usually T-cell mediated rejections up to about a year are about less than 10% these days, more in the range of about 4 to 6% or so. So if you use adequate thymoglobulin dosages, unfortunately in India, many centers use smaller doses, usually sometimes 1 to 2 milligram per kilogram body weight. But although the KDIGO would recommend about 6 milligram per kilogram body weight, but most Indian centers would use something like 3 milligram to 4.5 milligram per kilogram of thymoglobulin. Whereas for grapholon, although in India, usually 4 to 6 milligrams per kilogram is used, but we found that 4 to 6 milligrams per kilogram is inadequate, and the rejection rates were more than 10% with grapholon. And this has been published in Indian Journal of Nephrology. So grapholon, in our opinion, should be 7.5 to 9%, 9 milligram per kilogram body weight. So that's the dose that needs to be given to reduce acute rejections to a significant level of less than 5% or so, or less than 10%. So this looks like a T-cell mediated rejection. What is the reason you think it is T-cell mediated rejection? From why do you say so?
So based on the treatment given and the response, she responded well after
Yeah,
receiving.
she responded well to T cell mediated response to methylprednisolone. She only got methylprednisolone for 5 days, isn't it? She didn't get any other drug. And what is the kind of response rate to methylprednisolone of T cell mediated rejections?
So it is around, sir, 70%.
Yeah, around 75%. 70% of patients will respond to more than 70. So she responded to and the creatinine came down, and she was back on the follow-up on a regular immunosuppression. So when you get rejection like this in a patient and you are the treating physician, so what is it that you will tell the patient now?
Sir, I will tell the patient to be compliant to the follow-up and to
Yeah,
the
it's
medication.
extremely important to keep on emphasizing to the patient the compliance of drugs. These are not like any other medicines that they can forget to take, or so every visit that you see a transplant patient, do emphasize the need for continued immunosuppression, and also the timing of the drugs, the dosages, and they should order these drugs maybe a week before their drug is going to finish, so that there are no days on which these drugs are missed. So it's very, very important to keep on telling. And obviously, many times you might do tacrolimus levels in a long-term patient only to find out whether the patient is compliant with tacrolimus or not. You may not need to modify the dosages, but just to know that they are compliant. Okay,
Yes.
go ahead.
And during the further follow-up from 2018 to 2019, patient was apparently well with her creatinine level ranging between 1.5 to 2.2, and tacrolimus was also within appropriate range, and her blood pressure and blood sugar were well controlled on medication. But in July 2020, she developed a fever with chills and generalized body ache and features of upper respiratory symptoms, followed by shortness of breath, for which she was admitted in IGIMS Patna, which was the designated COVID hospital at that time, for approximately 15 days, and she was diagnosed with COVID-19 and her dengue fever, along with the dengue fever. And during her illness, she received IV medication and oxygen support, and her MMF was kept on hold, and her dose of prednisolone was increased. She had no decrease in.
So you think in 2019, obviously people didn't know what to do with immunosuppression, and I think at that point of time we did reduce immunosuppression and reduced especially MMF, or we didn't use MMF in many cases. So what was the kind of evidence which emerged after the COVID? So if a patient was to develop COVID now and you were the treating physician, so what would be the amount of evidence that came out of COVID 2019 to 2020? What was the kind of evidence, and what should we do to the immunosuppression in these patients?
So currently, sir, when a patient comes with COVID-19, we will stop the anti-metabolite, as there is no evidence of, as patient has we need to reduce the
So was there evidence to suggest that those where MMF was reduced or stopped, they did better than those where MMF was not stopped? Have you read the COVID literature on transplantation, or you haven't?
so I have read it from textbook.
So
COVID-19.
what did the textbook write?
So this, it is written that the MMF is stopped and it is restarted after 5 to 7 days after the
Yeah,
patient is
so
symptomatically better.
that is the general kind of a thing which is done. But I think specifically for COVID, there was evidence. All of us did what you did to this patient, but I think the evidence was that MMF did not change the outcome of these patients. Whether you continued MMF or you didn't continue MMF, the outcome of those patients wasn't any difference. The mortality and overall rejections or anything did not change. The only thing that changed was what? Can you tell me one thing which was,
Rejection.
no, what was different in people who continued MMF?
Sir, who continued MMF had
What was,
lower episode of rejection.
yeah, one was leukopenia. The second was their response to COVID vaccination
Oh,
was poor, especially Doris Sagiv's data from John Hopkins when he analyzed this. The immunogenicity of the vaccines was dwindled or lower, and this happened with both the Moderna vaccine as well as the Pfizer vaccines that they had access to, and so their COVID responsive sort of vaccination levels and titers were poorer. So almost dropped about less than 50% or so. So that's what was different in people who were continued on MMF and those. So those who were on, okay, okay, go ahead.
and at that time, her creatinine level increased to 3 milligram per deciliter at the time of discharge, and her MMF was restarted after 2 weeks, and she was stable and under regular follow-up from 2020 to 2022 with serum creatinine in the range of 2.5 to 3 milligram per deciliter, an appropriate range of tacrolimus, and good control of BP and blood sugar level on medications. Still, the patient had poor compliance.
Do you have any level of proteinuria ever? I think as a nephrologist, you should be concerned about that this slow progression of a kidney disease has started occurring. The creatinine is from 1.8 to 2.2, then 2.2 to 2.5, 2.5 to 3. So slow deterioration in kidney function with declining GFR. I haven't seen any mention about, was there ever a proteinuria ever done or looked at? Because
Sir, she doesn't remember the exact proteinuria value.
but the kidney follow-up in these patients, when the patients must be having some record of a transplant.
Yes,
Transplants are usually kept in institutions. They are kept with a great degree of, at least I would guess that IGIMS must also have some kind of a file which is given to the patient, or at least in the record somewhere. So
yes,
where they could have been. So you couldn't find anything about the proteinuria,
sir, exact.
because that's something which I find missing. I would have looked for as to find out whether this declining GFR in this patient with creatinines of 2.5 to 3 milligram, there isn't any mention of what happened to it. Did she have some degree of proteinuria? Was it, how much was it? As a nephrologist, somehow I find that nephrologists also don't look at proteinuria is a damage marker of the kidney. And this is something that can be done. Nowadays, we can do something about proteinuria. And declining proteinuria or giving people drugs to reduce degree of proteinuria slows down the deterioration even in the transplant patients, as well as it does in the native patients with native kidney disease. So I think proteinuria is something that you should be looking for. I would have wanted that you tell me that I could not find degree of proteinuria in this patient. So as a presenter, I would have expected you to say that there wasn't any mention about protein excretion in the urine and it was not measured. Okay?
Yes.
Okay, go ahead.
In March 2023, patient developed fever which was of high grade and was associated with joint pain and headache and was associated with retro or vital pain, and her platelet count declined to approximately 40,000. However, there was no bleeding manifestation, and she was admitted in the hospital for about 7 days, and again her MMF was put on hold during the illness, and she was diagnosed with dengue fever, and serum creatinine level increased to 3.5 milligram per deciliter. And progressively, during the further follow-up, her creatinine increased to 3.5 to 5 milligram per deciliter over the next few months. And in August 2023, she was counseled about the failing graft and the need of renal replacement therapy over the next few weeks or months. And her anti-hypertensive medications were also increased based on her home BP record. And at that time, her MMF was stopped and she was continued on tacrolimus and prednisolone. And she was examined for the whether her AV fistula was working functional or not, and she was further continued on dual immunosuppression, that is prednisolone and tacrolimus.
Why were dual immunosuppression continued?
Sir, we cannot stop the immunosuppression. Otherwise, patient first we will have to look in a failing graft if we are having what is the course of the graft failure. If it is a graft failure with a stable course or stable level of creatinine, or it is a rapidly declining GFR. So if, after that we look whether the patient is having any transplant prospect or no transplant prospect. If the patient is having a transplant prospect, then we'll have to continue with the immunosuppression, as the patient might develop sensitization, and with the next transplant
Yes,
patient.
it's extremely important that when you are looking at failing graft, it's very important to assess what is the likely next course. So all these must be discussed with the
Yes.
patient. That would she like to go on? Is there a prospect of a second transplant that she would like? She was 36 and she's only become 39 probably in these 3 years or 4 years of her first transplant. So she's still very young, and the only thing that will give her a long-term survival benefit would be a kidney transplantation over dialysis. So
Dialysis.
if there is another prospect of a transplantation, either a living donor transplantation or a disease donor
Disease.
transplantation, then these must always be explored, and then immunosuppression in modified forms should be continued in these patients to prevent sensitization
Sensitization.
with the persistent graft that is there in the kidney, in the patient. So it's important. So that's why it is good to continue tacrolimus and steroids in small dosages, and the dose of tacrolimus may have to be lowered once the renal failure becomes advanced, and then you can measure tacrolimus levels and keep it around 4 nanograms or so, so that the TAC toxicity in renal failure can create severe hypertension, uncontrolled hypertension, headache, and convulsions also. So you should be aware of the dosages and must modify the dosages based on the TAC level. Okay. Okay, so that is what was done in this patient, and I think I'm glad that that was still kept. There are many patients where these discussions are not done, and immunosuppression is stopped all of a sudden, and then these people get sensitized, and therefore second transplants or further transplants become difficult, more and more difficult. Okay.
Yes. In November 2023, patient visited her native place, that is Darjeeling, and gradually she developed swelling over the body and decrease in her urine output and uremic features in form of nausea, vomiting, decrease in appetite. And she developed one episode of epistaxis. At that time, her BP was found to be 200 by 110, and on further investigations, she was found to have her creatinine level of 7 milligram per deciliter. And after receiving primary treatment from Darjeeling and symptomatic improvement, she came back to IGIMS, and then she was admitted in December 2023 and was started on hemodialysis thrice per week through the left brachiocephalic fistula. and she also received 1 unit of PRBC during the first hemodialysis session, and her antihypertensive medications were also optimized and increased to 3 drugs, and she was continuing her tacrolimus and prednisolone. She received subcutaneous injection for anemia, which was twice per week, and kept on maintenance hemodialysis thrice per week. In May 2024, her left AV fistula failed, and on evaluation uh, about further temporary vascular access, she was found to have blockage of her bilateral neck vein, and at that time, left femoral tunnel cuff catheter was inserted, and AV fistula was created in the right brachiocephalic region in May 2024, and she was started on hemodialysis through the AV fistula in June 2023 and 2024, and her femoral tunnel cuff catheter was removed. And simultaneously, she was counseled for the next transplant. Yes.
Can we stop here then?
Yes.
See, she had this graft which failed. What do you think were the causes of this graft failure? Why did this graft only last for about how much? 2016 she got the transplant, and 2023 she was, so it lasted only for about 7 years, isn't it?
Yes.
Less than 7 years. So why do you think the graft failed? Why did it fail?
Sir, first of all, sir, she developed an episode of rejection, which is a risk factor for chronic allograft injury, and then she had hypertension and post-transplant diabetes mellitus, which also contributes to the chronic allograft injury. And she also developed recurrent infections, and with each infection, her MMF was put on her immunosuppression drugs were decreased, and she was non-compliant to the MMF, and then all these factor contributed to the chronic allograft injuries.
So all of these, yes, you are right that many of these factors could have been the causes of graft failure in this patient, and her compliance to the drugs was also something which was questionable. And then the various factors that you said, could something have been done better? Better intervention and all that. I feel that overall, I will feel that I'm sure Vineet will get upset also, that when you have too many CRBSI, every catheter, first 2 catheters, CRBSI. So I think it's very important for nephrology units to train technicians and educate them how to handle these catheters. Be careful about the sterility when these catheters are being used, so that you can lower down the CRBSIs that are there. The CRBSIs that I find in this country are, and the more and more people, dialysis is becoming prevalent, and catheters are being more and more often used. Fistulas are not prepared well in advance, mostly because nephrologists don't talk about it as early. Patients also don't agree, but we are also not educating our patients enough so that they can make fistulas earlier. So all of these efforts need to be done by nephrologists. And I think this is something every one of us must do. And I think this is primary, that we find that whatever we may be doing may not be doing enough. I know there is a lot of burden of patients to each nephrologist everywhere, but still I think it's extremely important to preserve whatever we are doing well. And I'm sure Vineet, who is such a good interventional nephrologist, will be pained to see CRBSI happening in 2 episodes in this patient in the earlier, and then these vascular excesses getting lost for very short, acting only for about short period of time. They don't work for long periods of time. So which would mean that probably they're not prepared well. We don't pick up venous stenosis or arterial stenosis earlier, and we don't intervene early in many of these patients. So these are efforts. Our effort should be to improve the graft outcomes, whichever graft we say, and intervene early. be aggressive about diagnosis. Many times we feel creatinine of 1.5 has become 2, we don't intervene. We consider this is okay. Patient is not agreeing. So where biopsy needs to be done, proteinuria needs to be looked at. And these are things which need to be. And I think that was one of the questions which was asked, that what could have been done to prevent this graft from being lost in about 7 years of less than 7 years of time. Okay, go ahead. Let's look at the second transplant, because that has more questions also on that. Okay.
Her evaluation and transplant and workup for second transplant was started in September 2024, and at this time, her maternal aunt, who's 47-year-old with blood group of O, uh, was a prospective donor. And after detailed evaluation and clearance from the concerned departments and acceptable tissue and HLA typing, she was accepted for the kidney donation.
Yeah.
Sir, her kidney for the second kidney transplant, she was admitted in the kidney transplant unit on uh, 6th of January 2025, and kidney transplant was done on 9th, and her MMF was added again on 7th of January
So
2000.
what are the things that you would do prior to transplantation? See, patient comes to you, now you're talking to her about the second transplant. The relatives want to know, the first transplant lasted only for about 7 years. What is the likely chance that this kidney will last now? So what are the chances of second transplant versus the first transplant outcomes?
So the outcome are relatively poor, but as compared to continuing hemodialysis as the modality, transplant second further transplant has better outcome and better
So,
patient survival and better lower rates of complications as compared.
so transplantation would definitely be, even if it's a second transplantation, would be definitely a superior method of treatment in comparison to continuing on dialysis in this patient.
Yes.
Although the outcomes of second transplant may not be as good as the first transplant, they will be inferior by normally whatever studies are there, by what percentage usually. So if the first year, 5-year transplant survival, first transplant is say 85% or 90%, so what would be the second transplant survival, 5-year survival?
So approximately, sir, 60% or
No, that may be too lower, but about 5 to 10% lower than the first transplantation. So that's what most studies would say, first or second. So transplantation. So would you like to go for a living transplant or second transplant, or would you want to give an option of a diseased donor transplantation? What would be better outcomes wise?
so living donor transplantation have better outcome
Living
as
donor
compared to
transplantation
deceased.
will have better. Now, if you were to, this is a patient where there is sensitization now. There is a first transplant. She has received some blood transfusions and she has had a pregnancy. So all three sensitizing events are there. So what do you expect in this patient?
Sir, I will expect that patient will have a higher level of sensitization, so the chances of
So how will
hyperactivity.
you determine that sensitization?
So first of all, I will go for with the next donor. I would like to go for HLA typing, followed by CDC cross match, and then flow cytometry cross match, and we will look.
The donor that she has brought forth is a Mosi, isn't it? That means
Yes,
mother's sister. So
yes.
if mother was the first donor, so if she were to ask you, would you think a Mosi would be a better donor or someone else would be better donor, or you think Mosi is okay?
So better donor would be a sibling because because of the better HLA match and uh,
So so if you were to look at, before you decide that okay, you accept this patient for transplantation, so what would you do? The first test that you will want to do
so,
in the recipient?
So, first of all, sir, I will go for HLA typing followed by the CDC cross match. If the
No,
CDC,
I'm talking of the recipient. What test before? So somebody has a losing graft and they come to you and say that I need to go for a second transplant and this is likely my donor. So what would you do in this patient?
sir, if it is likely donor, sir, I will go for sir, virtual cross match. We can go for and
Yeah, you will look for anti-HLA antibodies first because you
anti-HLA
will want to find out how sensitized your patient is.
sensitize.
So you could do a screening test, which could be PRA level, but I would
PRA.
go for a person who is going for a second transplant to be more definitive as to what the outcome of that transplant is going to be. I would do even if the first transplantation anti-HLA antibodies were not done, but in the second transplant, they're mandatory. It is mandatory to do anti-HLA antibodies currently.
Yes, sir. So,
Whatever the cost of this, people might say that this is an expensive test, 35,000, 40,000 rupees. I think in the overall context of the cost of second transplantation, this becomes the most important investigation that you will find. How much is your patient sensitized? And then you will want to find out, are these donor-specific antibodies? For which you will have to do an HLA testing of the donor itself to find out, are they donor specific? Because that's going to be your donor, isn't it?
yes,
So you need to do an anti-HLA antibody of both class 1 and class 2.
class 2.
High resolution molecular testing of.
Yes, sir.
Anyway,
I'll go for
anti-HLA bodies currently on the Luminex are done as a high resolution test, so they will come as high resolution. But when you do a HLA typing, most of the time, these days now, many of us were doing low resolution HLA typing. But with high resolution typing, because you have an anti-HLA antibody which is in high resolution, the HLA typing of your donor also has to be high resolution. And fortunately, the cost of high resolution HLA typing and low resolution HLA typing is same. So these days, there is no reason why you should be asking for low resolution HLA typing. Always go for high resolution HLA typing. Okay, of your donors. The cost is same now. They're not
yes.
different. So if your center is not doing it, ask for that your center should upgrade to a high resolution testing. And if it is not done, then use an outside lab to get an HLA typing. These are extremely important things that you need to look before you go for a second transplant. So you need to find out, are there anti-HLA antibodies? And then are there donor-specific anti-HLA? What is the difference?
Sir, sir, if it is for the general population, that is that might not affect the outcome with a particular patient. But if it is against that particular donor, if it is donor specific, that will affect the outcome of the graft, the donor specific. So, sir, based on that, we will decide for the desensitization protocol for the further management of the patient to reduce the risk of graft failure. We will use specific treatment strategies accordingly.
Yeah, no, it's important to find out that the recipient does not have a donor-specific antibody. Now, suppose your patient has high level of donor-specific antibodies against the MOSI. And are the chances going to be higher that she's going to have donor-specific antibodies against MOSI or not?
Sir,
And if so, why?
Against sir maternal aunt, sir.
Yeah. Against maternal aunt, why do you think she should have more? It's important.
Because the first
how is
transplant
the first
was
transplant?
with
The
the
donor
mother,
is
so
mother.
she will have,
So
yes, sir,
obviously she is
cross
sensitized to mother.
mother.
And the mother and the sister, her sister is the second donor, likely donor. And this mother and the sister are likely to share the antigen.
Here,
So
actually.
there is very high chance that, so if she asks me that there is a paternal uncle and there is a brother or a sister available, and then there is a Mosi available, so, and they ask me as to what the choice should be, so who would you choose?
Sir, can you please repeat the options?
If there is a paternal uncle possible donor, a maternal aunt donor, and then a brother and a sister.
Sir, I'll go for paternal uncle because she's not exposed to paternal
Not,
antigens yet.
if there is a sensitized patient, 90% sensitization to HLA, PRA of 95% and above, both class 1 and class 2. So what are the chances of that person finding a donor to match? And if there is, tell me which donor is likely to become a donor or is likely to be accepted as a donor. And if you want to ask this patient कि भाई तुम्हारी किस्मत भगवान ने डिटरमिन करेगा, अगर तुम्हें डोनर मिलेगा बताओ कौन सा वो डोनर होगा, आप कौन सा डोनर होगा. For a patient who is highly sensitized, 37 years or 40 years of age, so what donor would you look for? Can anyone tell me?
The twin.
No, you twin to hai nahi. There is no twin.
Sir, then
There is no twin. At least not an identical twin. ठीक? Or
so she is not exposed to her husband's actually yet. So
she's not exposed? How do
so
you say
she's
she's not
exposed
exposed?
because
She's
of the
exposed to the
pregnancy.
yeah, there is pregnancy, so she. No, हमने तो आपको 4 choices दिए, 4 choices में क्या है? So what would be the best?
Paternal uncle.
2 haplo-matched brother or a sister. And what are the chances of a brother or sister being 2 haplo-matched, 1 haplo-match, or 0 haplo-match?
So 25%, sir, will have the haplo match. 50% will have 25% will have complete match, and
2
50%,
haplo-match. Yeah, 2
yes,
haplo-matches.
and then
50% will have
half of the
one haplo-match.
yes, one half
And
haplo match
25% will be 0
have
match.
no match.
No
Yes.
match. So which brother or sister would be very good?
So both the
Somebody with
haplo match
100%.
100%. Yes, sir.
So they
So-
share the same chromosome, basically same antigens, exactly the same antigens. So you don't form antibodies against your own antigens. So if a highly sensitized patient is there, though, you have to find out a brother or a sister, and God only can give you that kind of an HLA identical brother or a sister, and that can happen only in amongst the siblings. So you should look for a sibling as the best possible donor for that patient. Okay, for a very highly sensitized donor, isn't it? So that
Yes.
is what needs to be done. Okay, so this is one of the most important things that one needs to do. So in a lab transplantation, it's extremely important to talk to the lab people. You must know whether your lab is doing a good CDC cross-match, doing a good flow cytometric cross-match, and whether your tests for usually the anti-HLA antibodies are done these days on Luminex, and the virtual cross-match can be done once you have a high resolution HLA typing between the donor and the recipient. So you will do a virtual cross-match. Without doing the cross-match, knowing the anti-HLA antibodies and what are acceptable antigens and not acceptable antigens, you can do a virtual cross-match and then know that that cross-match is going to be negative. Okay, so that is how you can predict the outcomes of transplant. Otherwise, you will usually have high chances of an antibody-mediated rejection. So what is the other thing that when you are doing such transplants, the second transplant or sensitized transplant, so what are the other things that you need to talk to the patient?
Uh, uh, Sir, we need to talk about the surgical procedure outcome related to the complications of the
So
surgery. And
is surgery more difficult in second transplant?
yes, sir, it is relatively more difficult as compared to the,
Why?
sir, because of the less space available for the transplant. And
No, you have one. Where is the kidney put in the transplant? One iliac fossa, isn't it? So
yes,
you
sir,
have the other iliac fossa for the
iliac
second
fossa.
kidney. So the space is not good. Third transplant, yes, space would be a
Yes, third
problem.
transplant.
But fourth transplant, space would be a problem. So then those are difficult transplants. But second transplant, probably you could put it in the second iliac fossa.
Right, iliac fossa.
Okay.
Sir,
And so surgically it may be still okay. But what are the vascular thing that you will have to check? Is there a
sir, the patency of the iliac, so the external iliac veins to which we are going to internal iliac vein and internal iliac artery, and sir, the external iliac vein to which we are going to anastomose. So we will have to look at the patency of the
yeah, you
vessels.
look at the vessels and all that so that you don't cause ischemia in those areas. So those are things which need to be looked at. What the other thing which I thought we need to also discuss is what are the other challenges for second transplant? One is immunological challenges. Anything else?
The risk of infection with the further
Should we do a nephrectomy prior to doing the second transplant, or should
sir,
we keep the
ideally,
kidney?
sir, we should keep the kidney. If we go for nephrectomy, there is a risk associated with the surgical procedure, as well as there is risk of sensitization also. And as the
So
patient,
patients who keep kidneys inside, or you remove the kidneys. So where is the risk higher? Keeping the kidney inside or removing the kidney?
so removing the kidney has higher risk, as the patient will
Why?
become
Why?
the
You
patient.
remove the immunogenicity is in the kidney. So if you remove an immunogenic focus, why would there be sensitization?
Sir, the procedure is associated with complications,
Yeah,
and during the
procedure is
procedure,
associated with complications is understandable, but I'm talking of sensitization.
sir, it acts as a sponge to absorb the
Yes, yes. So the kidney might act as a sponge. So when you remove this, sensitization has already occurred in these patients because these antigens have been exposed and the body has been exposed to the immune system has been exposed to those antigens. So they already have memory cells and formed antibodies against these. So many of these, when you remove the kidney, the kidney which was absorbing many of these antibodies is not, all these antibodies rise. So removing kidney sometimes may cause aggravation of the antibody titers in many of these patients, and then they are associated. So unless kidneys become painful, or they get infected, or there's some bleeding, or there is some swelling, or an allograft
graft intolerance,
graft intolerance or something of that sort, then
resistant
only you
anemia.
will, or a malignancy, or there are other issues associated, then only the kidneys are removed. Otherwise, the kidney is not usually not removed in these patients. So it doesn't serve any good purpose also. Okay.
It
Okay.
provides a residual renal function also.
Yeah,
Some.
till the time the second transplant comes in, yes, there is some amount of residual function. Okay. So go ahead. So the patient received second transplant, and what was the immunosuppression which was used?
So she received ATG again at a higher dose.
So when you give induction in second transplant, so what should be the induction agent? So if you have used
It is a high risk
basiliximab in the first
transplant.
transplant, second transplant, it should usually, because these transplants are likely to be more sensitized patients.
Yes,
So
sir, it is a
then,
high risk transplant.
yeah,
So
so
we
this is a higher risk transplantation. So the dosages of induction agents, especially thymoglobulin, should be much higher. So you can use, if you are using thymoglobulin, 3 to 4.5 to 6 milligrams per kilogram body weight, and if you are using Grapholon than 7.5 to 9 milligrams per kilogram body weight. Definitely that higher dosage should be used in these patients. What are the other options? If you have a highly sensitized patients, you can't find a donor against which there are no donor-specific antibodies. So what would you do to these patients? These patients are keen for transplant. They don't want to stay long. So what will you do? What are the other
They do
options?
not have any life-related kidney transplant. They can go for, first of all, we can consider the
So
patient for.
the patient has donor-specific antibodies against MOSI. So
Yes,
suppose
sir.
this MOSI was there, or husband was a donor and you have antibodies against the husband. So then what are the other options which are remaining for this patient to get a transplant?
Sir, if we are considering the same transplant, same person as the donor, then we will have to, sir, consider for the desensitization protocol.
Desensitization is not, especially in highly sensitized patients, the 5-year survival. This kidney lasted 7 years. That kidney is not going to last for more than 5 years. So
Then, sir,
even though you do desensitization or anything, the chances of antibody-mediated rejection within first year is about 40%, and losing graft in 5 years is more than 50%.
yes, sir.
So it's 5 years later, she'll be again at the same point. Any other better alternatives?
Paired kidney, sir.
Yeah, if you have a large regional or a national paired kidney program, then you can find in a large pool of recipients and donors, you can find a less HLA incompatible donor, and you might be able to transplant. Anything else? Can you do a
Deceased donor,
there is
sir.
a donor swap donor. It's an
Yes.
ABO incompatible transplant, but the sensitization is less. So would you do an ABO incompatible swap with a less sensitized donor, or you think ABO incompatible would not be a good choice? So which is better, HLA incompatible transplant, second transplant, or ABO incompatible second transplant?
So based on the blood group, if it is
No,
so
blood group is not, obviously it is HLA incompatible. One of the donors is HLA incompatible, so you will do an ABO incompatible transplant. But the donor in this has much less HLA sensitization, whereas her own donor, likely donor, say husband, has the patient has very high level of sensitization against the husband. So would you accept a swap with an ABO incompatible transplant for her, or you think that's not a good choice?
Sir, ABO incompatible, sir.
So which is better, HLA incompatible transplant or ABO incompatible? If there was choice between two, which is better? Anyone else? ABO incompatible or?
Excuse me, sir, for a minute.
Anyone?
Most are saying ABO, sir. ABO
Yeah, most are saying, yeah, ABO incompatible is definitely better, because although there could be an antibody-mediated rejection, but fortunately that rejection is less than about 2%, whereas the chances of an antibody-mediated rejection in an ABO, in a HLA incompatible transplant, especially highly sensitized patient, would be 40% or so at the end of 1 year. So doing an ABO incompatible transplant is definitely a reasonably good alternative to a patient who is highly sensitized with a less. So you can pick up an ABO incompatible donor with less HLA sensitization or no sensitization in comparison to an HLA sensitized donor, and then desensitizing such patients. So desensitization is something that I would always give to my enemies. I will tell them, take this transplant, you do the transplant and suffer through the complications of all the things that a desensitization process involves. But so you would want to avoid the Chinese warrior said that you should win a war by avoiding the war itself. And in the same, in a transplant, if you have to fight an immunological fight, then try to go around the immunological fight rather than going through the fire of immunological fight in the patient. So try to avoid getting into the immunological war zone, because these antibodies have memories and they will hit you all the time. You may
Yes.
be okay for 6 months, you may be okay for 1 year, but they will come back and bite you. So HLA incompatible transplants are difficult transplants. So I would any day choose an ABO incompatible transplant with less HLA sensitization over highly sensitized HLA incompatible transplant. So ABO compatible paired kidney donation with less anti-HLA sensitization would be a very good possible alternative to this patient. Okay?
Yes.
Chaliye, aage chaliye, let's finish it. We are already 1.5 hours almost.
There was no intraoperative complication, and the patient had good urine output in post-operative period. During the post-operative period, on post-op day 6, she had purulent discharge from the upper 2 stitches, and her stitches were removed, and she was managed with daily dressing, and resuturing was done on 31st of January 2025, and she was discharged on post-op day 22, and her serum creatinine level was 1 milligram per deciliter, and she was discharged on a standard triple immunosuppression regimen, that is tacrolimus, MMF, and prednisolone. Currently, patient is stable and is not on any antihypertensive medication. And in the last OPD visit, her creatinine level was 0.9 milligram per deciliter. In the past history, there is no history of significant medical history in past. She is non-diabetic, and there is no history of any COX contact. She is past surgical history. There is no history of any surgical intervention. She has 2 siblings. No sibling has similar history in other family member, and she is married since 2009 and on mixed diet, no addiction or high risk behavior, no food allergies, and is educated up to graduation. And an obstetric history, she
Is there anything in the history which is important, or anything in the examination which is important?
no, sir, I have summarized the case.
Okay.
And sir, I have kept the provisional diagnosis also, sir.
Yeah, no, these are not provisional diagnosis. These are your diagnosis. See, go to the diagnosis. See, you had first transplant, and that had a post-transplant diabetes mellitus. Where is your first slide? The provisional diagnosis? Yeah. There is one before this. Yeah, PTDM, hypertension, acute cellular rejection in the first transplantation. She gets COVID, dengue, first graft failure, then chronic allograft injury. What is chronic allograft injury usually? Currently, what is chronic allograft injury? What was called CAN?
So in 2005, they changed the terminology, and now it is a, sir, uh, after ruling out the specific etiology of the chronic allograft dysfunction, we keep the diagnosis as chronic allograft injury, and
Yeah,
histologically.
it's mostly a chronic antibody-mediated rejection. So by and large, it's related more to either iatrogenic or the non-adherence of the patient to the drugs. So usually related to those, or multiple acute rejections, infections, which is what induces an antibody-mediated rejection in these, because of de novo donor-sensitive, donor-specific antibodies, or you may have preformed anti-specific antibodies. So those are the things which are, these days you don't call chronic allograft nephropathy. So I think in this patient, I think the predominant problems have been that the graft survival in the first transplant was on the lesser side. Ordinarily, the current era, people are thinking of one transplant for one's life. So what are the methods by which you can ensure that one allograft or one transplant lasts for the life of a patient, which would mean that it would last current allograft survival on an average is about 10 to 15 years, maybe 20 years. But you're talking of 25, 30 or beyond years of life of a transplant. So how will you achieve it? So what are the challenges currently you and I have? So what are the things by which we may be able to succeed? Any
First of
idea?
all, sir, alloimmunization we'll have to before the transplantation.
Yes. So immunological evaluation of the patient. So a perfect immunological evaluation of the patient. And fortunately, these days we have all the wherewithal, not too expensive. Anyone who says that these immunological tests are expensive doesn't know the cost of transplantation in the overall terms of transplantation in the life of that patient. So I think you should not compromise on the immunological evaluation of the patients at all. These days, these costs have become really, really good. So I would do all that I can have my hands on for immunological evaluation. So that's one. Second,
Sir,
good nutrition in your patients. So don't tell your chronic kidney disease patients to stop dal and do milk and um, proteins of any kind. Vegetarian people cannot have enough proteins as such. You will have to give them protein supplements to give them enough proteins for. So chronic kidney disease patients don't reduce proteins in India at all. And even in non-vegetarian people don't reduce. No Indian is taking proteins more than 0.6, 0.7 grams of protein per kilogram body weight. So they become malnourished by the time. So malnutrition is a poor outcome in transplantation. So we must maintain our patients on good nutrition, be they prior to transplantation, prior to dialysis, and on dialysis. Ensure that in addition to giving good quality dialysis, give them good nutrition. Third thing,
balance between, sir, immunosuppression and the risk of infection.
yeah,
It
so
should be
choose your immunosuppression in such a manner and do a regular follow-up of these patients. Talk about compliance to drugs and monitor for over immunosuppression and under immunosuppression. So what are the things by which we can monitor over immunosuppression or under immunosuppression? How do you objectivize it? Anyone?
Sir, the level of immunosuppression, specific drug levels can be measured, and we can for
Yeah, one
specific.
is at the moment we have drug levels, although drug levels we do it only for tacrolimus, we don't do usually levels for mycophenolate mofetil. So drug levels have an issue because we go by rule of the thumb. We don't know whether every patient requires that kind of TAC level. At the moment we say 4 to 6, but I'm not sure whether every patient requires that. What is it in every patient? I don't know. So how do you determine whether your immunosuppression is adequate, over immunosuppression, or is there a test which is evolving?
Sir, LE spot, sir, for the
LE spot is one of the tests. Yes, it's not as easily available. Anything else that is being talked about? You heard of talk tenovirus?
yes, sir, TTV. Yes, sir, it is done from the saliva and for the to assess the level of immunosuppression, but it has not it has not
Yeah, we
been
don't know
approved.
yet, but
Yes,
this
sir.
is one method. And then you can do BK virus monitoring and
PK.
cytomegalovirus monitoring in the early transplant period. If these are higher, either in the blood or in the urine, some people do it in the urine, and to look at if these are higher, then you know that your immunosuppression may be higher and you need to cut down. If rejections are occurring more often, then you know that your immunosuppression is on the lesser
Inadequate.
side. And if you have TTV, or you do antibodies test, HLA antibody screening test during the post-transplant period. Because if you have anti-HLA
Yes,
antibodies,
sir,
you
DSA
know that,
monitor.
yeah, so you know that your immunosuppression is on the lower side.
Protocol
You need to go
biopsies can
up
be
on
used.
the run. So, or doing a protocol biopsy. So these days, combining these methods of protocol biopsies and looking for anti-HLA antibodies in the post-transplant period, TTV, tenovirus, and then BK virus and parvoviruses and other viruses which talk of higher immunosuppression, you may be able to find out where your patient is, and you might be able to monitor these patients on a much higher level. So I think I must thank you for presenting this patient, and also this, I think if there are monitoring by donor-derived DNA, clinically a bit difficult test, but all of these are evolving tests, yes, which can be used effectively. We don't know yet the best method to monitor these, but at the moment these are evolving, and these may have to be incorporated in our day-to-day practice so that we can manage our patients in a better way, so that one transplant lasts for one's lifetime. This is what at the moment the holy grail is. Tolerance looks to be at the moment not achievable, because most centers which were looking at tolerance have given up at the moment. Now people are looking at xenotransplantation as an option and other things. So we will have to wait for the other things that are likely to happen in the area of transplantation. Any question you have?
Uh,
क्या जी?
Thank you, sir. This was a very practically oriented bedside, and we also learned a lot of new things. There are some 2-3 questions which some people have asked. Like one is, Dr. Mradula, can you please tell like TAC levels in this patient in your institute are being done by LCMS or immunoassay, because these days LCMS is more accurate and more sensitive, and most of the institutes are doing LCMS. So it is important to tell in
yes,
history that whether
that was-
LCMS was done. So
yes, ma'am. LCMS test was done for, like, we do it by that method only.
Yeah, the problem only is, Jasmine, is that LCMS is a good machine. It's like a Stealth B-52 kind of a plane, but you need a good pilot also to navigate that plane. And unfortunately, I think LCMS machine is a very sophisticated machine, but unfortunately, I'm not sure that all labs have good people to manage it. So I know of LCMS machines giving you junk reports on tacrolimus. It's true that LCMS is a better method than, so it's important to see that what method suits a particular institute. So I think it would be good to look at local expertise available in that area. You may have an LCMS method, but if the person is not able to give you good, reliable reports, reproducible reports, it's useless. So I would not mind somebody doing other tests as such, but as long as the tests are reproducible. And as a nephrologist, you must talk to your lab. Please be in touch with them. Go to their lab and see how they do these tests. And you will find out for yourself what could be the mistakes and what could be the methods by which you can improve those methods. If you are on their head, they know that here is this doctor who is want more reliable and reproducible reports. Okay? Jasmine, second question.
Sir, in your practice, what do you suggest? Like for low immunological risk patient, do you suggest that we use induction in all the patients for low immunological risk patients?
See, I think, I don't know what would you consider as a low immunological risk. If there is an HLA identical donor, then you don't need any induction agent. If there is somebody who's got an 50% HLA identical, it's like parents, brothers, sisters, and spouses will be unrelated and 0% match usually. So HLA 50%, we have published in Indian Journal of Nephrology our data on induction. Is not a randomized trial, so it's a observational trial, and you go a retrospective analysis of from 2014 of about large number of 1,600 patients, and we've picked up HLA 50% HLA identical, one haplomatch donor recipient pairs, and looked at thymoglobulin basiliximab in about 1,200 patients which have been analyzed, 400 no induction, 400 basiliximab, about 400 patients in overall. out of them, we picked up about 400 patients with HLA, one haplo-HLA identical, and which are parents, brothers, sisters, and those are the donors. And we looked at induction agents, these 3 induction agents, no induction, thymoglobulin, and then basiliximab. And we find that thymoglobulin, no increased infections related to thymoglobulin in these 400 patients. And I can tell you 1200 patients also, which we have analyzed, there's no increased infection. When you use 3 milligram per kilogram, that seems to be the sweet spot for thymoglobulin dosage in Indian patients, I think. And so I think we find that the rejection rates were lower. Basiliximab actually, in my opinion, is the same rejection rates and same infection rates as compared to no induction. So if basiliximab, no induction are same, thymoglobulin reduces acute rejection significantly to less than 7-8%, is about 7-8% it was. So it's already published in last year in Indian Journal of Nephrology, this HLA identical, and the rest of the group is also likely to get published in near future. But our experience with thymoglobulin induction, in my opinion, probably at the moment, I would feel that what we do currently is that we ask patients that if they can afford 2 lakhs of rupees, and if they can keep 2 lakhs of rupees additional for emergency care that might go astray, and if they can easily do that, then I would use thymoglobulin. If they cannot do it and they don't want to, we do without induction. Basiliximab we use only in ABO incompatible transplant at this point of time. So no induction, basiliximab, and thymo in most of the other patients who can afford. But we do transplants without induction.
Okay. So there is an interesting question, like if you get a allograft biopsy that shows CNI mediated nephrotoxicity, first is we optimize the CNI levels, but if the CNI levels are optimized or normal only, then what is your protocol? Do you shift one CNI to another CNI, or do you pick mTOR inhibitors?
The only way, I don't know, this CNI toxicity was talked about when cyclosporin was being used with tacrolimus. CNI toxicity, small, very small. I don't think I have seen that much of CNI toxicity. So I would continue to use CNI as a backbone of almost every transplant. So we would reduce if we find that there is somebody who has creatinine going up, and I find that there is acute tubular necrosis predominantly. That's what I find. I don't know, and there is no other reason for acute tubular necrosis. It looks like an ischemia related to the calcineurin inhibitor. So I have done that, removed tacrolimus. I don't change to cyclosporin then. I would remove tacrolimus for some period of time and get the patient on everolimus and mycophenolate mofetil. I have had few patients. This is a difficult thing to do in the very early transplants because you would want tacrolimus actually in very early. But sometimes you get into difficulties, and in very few patients, you might have to change it. And we've been able to navigate it all right. And once the patient is all right, 6 months to 1 year down the line, I get them back onto everolimus when the dosages required are small and the TAC levels to be maintained are on the lower side. So usually they are able to tolerate tacrolimus better. So I have done that many times, and there are few patients who have continued on everolimus and mycophenolate. They have also done well. But this is a more expensive immunosuppressive therapy also, and probably not the best one. At least the US data suggests that mycophenolate and everolimus combination is not the common or a choice that you would want to use, but maybe in a patient where you tacrolimus toxicity, I think with tacrolimus I see less of toxicity as compared to cyclosporin. I used to see more cyclosporin toxicity.
Dr. Vineet, are there any other question, or we can close the session?
I think we have covered most of the questions in a discussion. And ma'am, you can give the closing remarks.
Thank you, Kher sir, and thank you, Vineet sir and Dr. Mradula. You presented very well, and thank you, sir, for taking this bedside. It was a very educative one. So we thank all the participants who actively participated in the chat discussion. It was very nice to see all of you actively answering all the questions. So thank you all. We'll close this session now. Good
Yeah.
night.
No, thank you very much. It was a pleasure being part of this, and I would like to also congratulate Mradula for good presentation.
Thank you, sir.
Thank you, sir.
Okay, and thank you,
and
Vineet.
Good night.
Good night. Bye-bye.
Thank you, sir.